Andrew, the internet makes time-restricted eating sound like a secret metabolic switch. Eat in 8 hours, fast for 16, and your body just handles fat and glucose better. Is the eating window itself doing something powerful, or is it mostly a cleaner way to eat less?
It is not magic, and it is not one single diet. Time-restricted eating means you keep your food and caloric drinks inside a consistent daily window, commonly 6 to 10 hours. In the diabetes risk trial, people used a 9-hour self-selected window and finished by 7 p.m. In another obesity trial, people used an 8-hour self-chosen window and ate ad libitum, meaning no formal calorie target. The clearest behavioral change is fewer eating occasions. In the 12-week randomized trial, the TRE group ate about 1.1 fewer meals or snacks per day, was much less likely to report breakfast, and reduced energy intake by about 469 calories per day for baseline. That is a big clue. The window can work by removing opportunities to eat. But that same study also noticed drops in potassium and total grains, not just saturated fat and refined grains. So an eating window can simplify decisions. It can also squeeze out nutrient-dense foods if the meals are rushed or repetitive. The window is a container. Vegetables, fruit, protein foods, fiber-rich carbohydrates, and unsaturated fats still have to go inside it.
So, if the calorie drop explains a lot, why do people keep emphasizing morning windows? Is there a real circadian reason to finish earlier, or is early TRE just a wellness upgrade label?
There is a real rationale. The pancreas, liver, gut, muscle, and fat tissue all run on circadian clocks. Eating is one of the signals that tells those clocks what time it is. Late energy intake can push digestion, glucose excursions, and thermogenesis into a period when the body is preparing for sleep. That does not mean every late dinner is harmful. It means timing can change the metabolic context of the same meal.
What happens when we stop talking mechanism and look at glucose outcomes? If someone has prediabetes or is worried about type 2 diabetes, should they expect their HbA1c to move?
That is where medical context matters. If someone uses insulin, sulfonylureas, or other glucose-lowering drugs, a longer fasting period can change hypoglycemia risk and medication timing. Pregnancy, active eating disorders, frailty, undernutrition, and complex kidney or heart disease also change the calculation. TRE is a meal timing strategy, not a reason to improvise with prescribed therapy. The 2026 meta-analysis of randomized trials in prediabetes or type 2 diabetes found moderate certainty evidence that TRE lowered fasting glucose by about 0.30 millimoles per liter and body weight by about 1.6 kilograms overall. HbA1c, however, did not show a clear overall effect. In subgroup analysis, prediabetes showed a small HbA1c improvement, while type 2 diabetes did not reach a clear HbA1c result. And the larger diabetes risk trial is useful because it did not compare TRE with nothing. It compared a 9-hour window, ending by 7 p.m., with individualized dietetic guidance. At 4 months, TRE was non-inferior for HbA1c, but not superior. At 12 months, non-inferiority could no longer be concluded, and the absolute HbA1c changes in both groups were small and not clinically meaningful. So the best fit user is not everyone who wants a hack. It is someone whose excess intake comes from evening grazing, alcohol calories, snack stacking, or chaotic meal timing, and who finds a time rule easier than counting every portion. If their diet quality is poor, TRE may help only if the smaller window makes better meals easier, not if it compresses the same pattern into fewer hours.
But the trial you mentioned had people skipping breakfast more often. If early windows are theoretically better, how do we square that with real people choosing noon to 8 because it fits work and family?
Exactly. A window that worsens sleep, training, mood, or family meals is not automatically healthier. Athletes, older adults, and postmenopausal women need enough protein and total energy across the day. In a Nordic walking trial, the package with high protein plus TRE looked better for strength and lean mass patterns than walking plus TRE alone. So we should not isolate fasting from nourishment.
If someone tries it responsibly for a month, what should they measure besides the clock? Scale weight? Fasting glucose? Hunger? Or is the better question whether the window improved the rest of the diet?
I will make it boring on purpose. Pick a 10 or 9-hour window first, preferably ending 2 to 3 hours before bed. Keep protein, fiber-rich plants, and minimally processed staples visible. Do not compensate with a huge last meal. After 4 weeks, ask, did calories likely fall? Did sleep hold steady? Did cravings improve? And did the pattern feel repeatable on normal weekdays?
What are your stop signs? Because a lot of people treat a longer fast as automatically better, even when they're cold, irritable, binging at night, missing protein, or getting dizzy during workouts.
The cleanest bottom line is this. Time-restricted eating changes when eating can happen, and that often changes how much eating happens. It may modestly lower weight and fasting glucose, especially when it removes low-value calories and avoids late-night intake. It is not clearly superior to good diet guidance for HbA1c, and it does not replace food quality, adequate fueling, or medical supervision when medications are involved.